Engaging talk by Dr. Guru. It was quite nice. Now I am worried because my topic is a serious one. Okay, myself Dr. Manikandan from Ganga Hospital, Coimbatore. And I chose this topic by choice because I had only this ready when I was approached last week by the organizers. And I had recently taken it for my fellows in the department. And please don't think that I am known for infectious complications. So how many of you have seen these complications in your practice, like epidural abscess or meningitis? Can I ask you a question? Quite few. Yeah, it is very rare and it is subjected to underreporting also. That's the problem. Okay, so then we should know what is the incidence. Many of the national surveys show that the incidence may range from 1 in 40,000 to 1 in 1 lakh, which is misguiding. But the recent studies which have better criteria for diagnosis have shown that the complication is quite high. Like if you can see from the bottom one, the incidence may range from around 1 in 1,000 to 2,000. Okay, let me start with this case report of an epidural abscess. This is an nulliparous woman receiving an epidural for analgesia. Her epidural catheter is removed 6 hours after. She develops progressive back pain which gets severe on the day 5. Till then she never develops any fever or leukocytosis. Later on, with the fever, they decided to take a CT scan, which was inconclusive. Then when she developed a neurological deficit, they decided to do an MRI, and they found a large triangular abscess compressing the thecal sac. And they immediately went for surgical decompression, and she went for complete remission. So we need to remember that we need to be highly suspicious with the epidural abscess, and at the same time, MRI is the investigation of choice. So the classic triad of back pain, fever and variable neurological deficit will be seen in very minimal number of patients, leading to a diagnostic delay in 75% of them. Often the damage is greater than the degree of compression, not only because of the compression, because all the ischemia of the vessels and compression of the arteries will aggravate the damage. So most commonly the culprit is Staphylococcus aureus. You meet the hospital staff. So I have some large collection of epidural abscess. These are one of the largest. You can see Staphylococcus aureus, the topper. In whom do we need to be cautious really? I would be careful with lawyers, doctors, politicians, and sometimes the other risk factors like compromised immunity, duration of catheterization more than 2 days, disruption of spinal column in an anesthesia setting would be repeated punctures and difficulty in insertion. And if there is a source of infection like already present systemic infection or breach in your sterile practice. Okay, this is another dreadful complication. This is one of the recent report in a well-developed country with 5 cases of meningitis happening immediately following spinal anesthesia for cesarean section. These women were apparently healthy and did not have any predisposing factors. And the presentation was appeared as the 2 clusters of meningitis associated with one single anesthesiologist. In one cluster, they were able to identify the identify the organism, which could be isolated from the airway of the anesthesiologist. And in the other one, the operating room was open to unmasked visitors. So this is one of the largest collection of post-dural puncture bacterial meningitis. You can see there are meningitis happening across several countries, and it can happen with anesthesiologists, neurologists, pediatricians and radiologists. For a community acquired pathogen to develop a meningitis, it has to undergo through several stages like colonization of the nasopharynx, invasion of the epithelium, entering into the bloodstream and crossing the blood-brain barrier. But for a pathogen which is entering through the lumbar puncture, they all circumvent the first 3 obstacles and they directly cause the meningitis in a rapid progression. So the culprit here would be the nasal commensal, which are frequently Streptococcus salivarius and Streptococcus viridans. And how does the organism gain entry into the CSF? So as I said, most of them are nasal and oral commensals, and looking at several clusters of cases of meningitis, the operator-related role is the most important. So this is the tip of the electron micrographic picture of a stylet, which shows starch particles when it was touched by the sterile glove. So the authors advise that you should not touch the tip of the spinal needle or the stylet in any case. So that's how a needle can be contaminated very easily. Looking at the differences between the presentation of epidural abscess and meningitis, meningitis is more of CNS manifestations like altered sensorium, headache, stiff neck, whereas epidural abscess will present as neurological damage and back pain. So the treatment will be just like a community-acquired meningitis. Most of them will require a course of dexamethasone and antibiotics. We may have to investigate using CSF analysis, before which we need to rule out the contraindications, and by taking a negative CT scan. Okay, what about the peripheral nerve blocks? They may be relatively more frequent, as you can see from this slide, but the complications are relatively less severe. Sometimes there are serious infections like abscesses, and I want you to concentrate on the left column, which are the scientifically proven factors associated with increased incidence of infection. If there is any reason for stay in the ICU, or if the catheter is greater than used for more than 2 days, absence of antibiotic prophylaxis, axillary and femoral catheters have high incidence because there are a lot of sebaceous glands in this area, and also frequent dressing changes is another factor. So this is one of the serious complications reported with the continuous epidural, continuous interscalene catheter. This patient underwent shoulder arthroscopy and received this infusion. 3 days later, the patient developed neck edema, erythema, and fever. Blood culture showed Staphylococcus aureus, and he required surgical decompression. So finally, they narrowed down that the cause would have been the nurse who loaded the bottles of local namely 6 bottles of local anesthetic into the elastomeric pump. That's how we actually load the drug, right? So what is the thing about it? We'll see about it later. So here again, the commonest organism is Staphylococcus aureus, which is a skin flora. 20% of us are persistent carriers of Staphylococcus aureus, and 60% of us are intermediate carriers. So this is only the severe case report of an associated with a single shot block. This woman received, diabetic woman received an axillary plexus for carpal tunnel surgery. 4 days later, she developed edema, diffuse swelling, and bullae. Toxic shock syndrome was suspected, and Streptococcus pyogenes was isolated, and the patient died 48 hours after surgery. So here they found that the source of infection could have been the anesthesiologist who did not wear a mask, and again they used only betadine for axillary disinfection. So there are several guidelines which have been published for prevention of infectious complications. One of the recent is the American Society of Anesthesiologists. It would be good to know the risk factors associated with it by a good clinical examination and history. If you suspect a bacteremic patient, then consider pre-procedure antibiotic therapy. Right. These are the general precautions which you may know. I want you to concentrate on the last 4, which we generally don't do, at least in our state. Individual packets of antiseptics for skin preparation, chlorhexidine for skin preparation. How many of you are using chlorhexidine? Can you put your hands up? So it's, yeah, that's quite a few. Okay, and again, we should limit the disconnection and reconnection of infusion systems. And if you find a disconnected catheter, please consider removing the catheter. And even after the procedure, after aseptic style, you have to look for periodical symptoms and signs and order appropriate investigations in time. And we need to periodically check the neurological infection also, neurological function also. Hand hygiene is the most important and powerful component of aseptic technique, which is being enforced by the WHO. Even the concept is 165-year-old, it is the most neglected component. And we should remember to perform hand hygiene in 5 moments, especially we forget before touching the patient and after touching the patient's surroundings. Okay, face mask and surgical gown are the most controversial topics here. There is no uniform agreement between the experts, but still it is reasonable to wear face masks because we have seen many case reports and complications. This study, which I want you to know, is by Phillips and colleagues, where they placed an agar plate in front of the operator. They asked them to speak, because we always speak to the patient when we perform the spinal anesthesia. So when they placed the agar plate in front of the operator, they found that face mask prevented contamination of these agar plates. And again, you had seen that many of the spinal meningitis were associated with the nasal command cell from the operator. And next comes the question of which is the best antiseptic to be used. Now it is quite established that alcohol-based chlorhexidine is the best one. So what are the advantages of alcohol-based chlorhexidine? Wider spectrum, rapid onset, because alcohol is just nasty with the bacteria, and more importantly, chlorhexidine has a sustained duration of action because of penetration of the stratum corneum. It stays there for several hours, and it penetrates the hair follicles. Especially it will be important in axillary and femoral area. Right. So I know you don't like this slide. This is a study about the efficacy of 3 different solutions like povidone iodine, chlorhexidine and chlorhexidine in alcohol, which we commonly use. So the effect on 6 strains on the surface of procedure, they found that within 15 seconds they were able to get a clean surface. You can see the colony forming units are 0 with chlorhexidine and 80% ethanol. Right. You may have seen these swabs, chlorhexidine single applicator during the live workshop by Dr. Sanjay Sinha. I don't know whether these are available in the country, but they are very useful. I have seen it outside, and the action will be very quick, and usually the surface is clean in 30 seconds. Okay, this is about multiple use bottles. This investigator found that 40% of the multiple use betadine bottles which we use in our country are contaminated. Right. And this is the least common risk factor associated with peripheral nerve and epidural infections, the infusate contamination. We need to know about this, and this is an excellent article. So we all know that local anesthetics are good antibacterial agents, but do the dilute concentration of local anesthetic which you use for infusions will be able to protect? No. Levobupivacaine and ropivacaine, which are quite popular these days, don't have much antimicrobial properties. And 2 important issues which we need to concentrate is the hang time and sterile compounding practices. Hang time refers to the maximum length of time over which an infusion can be given. So it is generally agreed to limit it less than 72 hours, even though the microbiological stability may be more than that. Okay, sterile compounding practice. I want you to read this carefully, because in United States pharmacopoeia, it is mandatory to keep the preparations to be infused over 24 hours, like the epidural infusion and peripheral nerve blocks, to be prepared in a laminar class 5 laminar flow workbench. What is that? See, if the air quality, environmental air quality can be graded from 1 to 9, where urban ambient air is 9 and the most cleanest atmosphere is 1. So operating room is at the level of grade 6, but it is not still sufficient. So they need a sterile hood with a laminar flow, which is ISA grade 5. So if you look at the pack of infusion, these are all prepared in the pharmacy by the pharmacist in a sterile atmosphere. And these conditions, this may be difficult to implement in our country because these conditions would not be met on the hospital ward, pre-operative ward, post-operative ward, or even the operating room, where any anesthesiologist is likely to work. Okay. Since we are using ultrasound guidance very frequently these days, we need to know about the infectious precautions with the ultrasound probe as well. The ultrasound probe is a non-disposable medical device. All medical devices have been classified based upon their required disinfection level, like non-critical, semi-critical and critical. If ultrasound is used by a radiologist, it is non-critical, but we are using it for blocks where it can be contaminated with blood and secretions, so it could be a semi-critical or even critical, which may need an intermediate level of disinfection. So when it comes to blocks, even if it's a single shot or a continuous peripheral block, it is a must to use sterile gel and sterile probe cover. Between 2 patients, please consider it as a non-critical medical device and wash it with a detergent. Probes and cables should be cleaned with the products that are recommended by the manufacturer, which you have to find it. And we always need to completely clean the ultrasound cart and keyboards regularly. Some of the alternative methods could be ultraviolet disinfection, which are being just evaluated, nebulized hydrogen peroxide, but I don't know how cost effective they are. At the end of the operating list, the ultrasound probe should be cleaned with detergent, rinsed, dried and kept in a clean environment. Okay, this is an image of an ultraviolet sterilization chamber which is being just evaluated. Okay. So finally, if you are able to identify the risk factors and perform the basic safety precautions, and if you are vigilant in the post-operative period, even after the procedure, we can avoid these complications. Thank you.